Please stand to sing the Montserrat national song, Motherland. Please continue to stand as I invite the Acting Community Nursing Manager, Nurse Alex Aki, to offer a word of prayer. Thank you.
We can all bow our heads, close our eyes. Gracious and Heavenly Father, we thank you for always hearing our prayer. Father, we thank you for the gift of wisdom and knowledge that you have bestowed upon us. And as we go about our deliberations today, Father, we ask you to stretch your hands forth over us. Bless us, guide us, and keep us so that we can impart knowledge to one another and towards this policy for the betterment of our people. Through Jesus Christ our Lord. Amen.
Thank you. Permanent Secretary of the Ministry of Health and Social Services, Mrs. Camille Thomas Gerald. Chief Medical Officer of the Ministry of Health and Social Services, Dr. Shara Greenaway Dubry. Sexual and Reproductive Health Commodity Security Specialist from UNFPA Sub-Regional Office for the Caribbean, Mr. Oguchi Odu. Consultant for the Sexual Reproductive Health Policy, Ms. Isola Garcia. Other UNFPA representatives joining virtually, and our valued stakeholders, including healthcare workers from the private sector, representatives from the migrant communities, government ministries, legal department, non-governmental organizations, community-based organizations, youth representatives, representatives from the faith-based organizations, and parents from the Parent Teachers Association of nursery, primary, and secondary schools in Montserrat. Good morning and a warm welcome to the in-country consultation on the development of the sexual and reproductive health policy for Montserrat. I am Dr. Faquida Watson-Jones, your chairperson for today's policy development and a focal point for the policy along with Dr. Erwin Mosley, the obstetrician and gynecologist. We are delighted to have each one of you here in contributing to this important discussion. The development of the sexual and reproductive health policy provides concrete areas of focus that will be essential in ensuring the fundamental rights of women, children, and adolescents to attain the highest level of health with the assurance of comprehensive, quality-driven, and gender service delivery that is appropriate, available, accessible, and affordable. This work is being implemented as one of the agreed activities in the Sustainable Development Goals Fund Joint Program entitled Integrated Population Data and Policy Solutions to Accelerate SDGs Achievement in Barbados and Montserrat. Ms. Garcia, the consultant for the Sexual and Reproductive Health Policy Development, has engaged with myself and Dr. Mosley in the implementation of this consultancy to include the following activities. 1, to conduct a synthesized desk review of related laws, policies, strategies, plans, and other documentation to examine the landscape and support the development of the sexual reproductive health policies in Montserrat. 2, conduct a mapping exercise to identify key stakeholders. 3, facilitate virtual consultation meetings with the MAP stakeholders to garner the feedback on the proposed policy's content coverage. And 4, use the desk review and consultation meeting findings to draft a comprehensive sexual reproductive health policy for Montserrat. Once the sexual reproductive health policy is implemented, new partnerships between governments and all the key stakeholders will be critical to succeeding in implementing comprehensive and integrated sexual reproductive health services. At this point, I would like to invite Mrs. Gerald, the Permanent Secretary of the Ministry of Health and Social Services, to give welcome remarks, followed by the UNFPA representative, Mr. Udu, to give brief remarks. Thank you.
Good morning, everyone. It is indeed an honor to welcome all of you to this SRH consultation. And a special welcome is also extended to Mr. Udu. That way I wouldn't get in any problems with the pronunciation of the surname. Sexual and reproductive health, SRH, encompasses a spectrum of physical, mental, and social well-being related to sexuality and reproduction. It extends beyond the mere absence of disease and dysfunction, embracing the freedom to enjoy a fulfilling and responsible sexual life free from coercion, discrimination, and violence. At the core of SRH lies the right for us to make informed choices about one's body and sexuality. This includes access to accurate information about sexual health, contraception, and safe abortive services. Providing individuals with the knowledge and resources to make these choices empowers them to control their fertility, plan their families, and determine their own destinies. In a world where women and girls are often disproportionately impacted by gender inequality and societal pressures,
Recording in progress.
access to SRH services is essential to achieving true gender equality. Beyond individual empowerment, SRH plays a vital role in achieving broader societal goals. It is intrinsically linked to achieving the Sustainable Development Goals, the SDGs, particularly those focused on poverty eradication, health and well-being, and gender equality. Investing in SRH programs lead to improved maternal and child health outcomes, reduce maternal mortality rates, and a decrease in unplanned pregnancies. Furthermore, by empowering women and girls to control their fertility, we can see positive impacts on educational attainment, economic participation, and overall societal development. However, despite the crucial role of SRH, many individuals around the world face significant barriers to accessing essential services. Poverty, lack of access to education, cultural norms, and discriminatory laws often prevent individuals from exercising their right to choose. This lack of access has severe consequences, leading to unintended pregnancies, unsafe abortions, sexually transmitted infections, and increased vulnerabilities to gender bias. Addressing the global SRH crisis requires a multifaceted approach. It necessitates dismantling the discriminatory laws and social norms that perpetuate gender inequality and restrict access to services. It also demands increased investments in education, healthcare infrastructure, and community-based programs that promote comprehensive SRH education and provide access to quality care. Crucially, the fight for SRH must involve engaging with all stakeholders, including governments, civil society organizations, healthcare providers, and individuals themselves. This requires fostering open dialogue, challenging misconceptions, and promoting a culture of respect and understanding around sexuality and reproduction, and that is why we are all here today. Although Montserrat is a small island, it has to play its part in ensuring that it takes the necessary steps to achieving the SDG goals, as we are a part of the global community. We are here as stakeholders to continue the process of developing our SRH policy. You may say that perhaps we do not have barriers, but we do. We may not have discriminatory laws, but we do. And that there aren't any restrictions to services, but they exist in our legal framework and in the delivery of some of our services. Please understand that I am not saying that we are doing everything incorrectly, as there are many positives within our systems, such as access to contraceptive measures, and the existence of medical and OBGYN services, nursing services, health promotion services, and the list goes on to support reproductive health. There are some things that we need to do, though, before we can get to the top of the ladder. It is necessary for us to check our groundings. We are at the bottom. So it's best for us to check our status, see where we are before we can get on to that top wrong, before we can get on to that first wrong. In our current situation, we identify the barriers that exist. And as we move up each rung, we will develop clear objectives to ensure that in the end, an approved policy is developed to the point where we would have removed the inhibitors and we would have made the appropriate legislative adjustments so that in the end, we can stand tall with the rest of the world. In conclusion, sexual and reproductive health is a fundamental human right that underpins individual empowerment, societal progress, and the achievement of global development goals. By ensuring access to information, services, and resources, we can empower individuals to make informed choices about their bodies and sexuality, fostering a healthier, more equitable, and sustainable future for all. The fight for SRH is a fight in a world where everyone, regardless of their gender, background, or location, has the right to live a fulfilling and healthy life, free from fear, stigma, and discrimination. In fact, I think that this very last sentence synchronizes well with the vision for Montserrat, and I'm hoping that everybody remembers what it is so that they can recite it with me this morning. And that is a Montserrat which is a healthy and wholesome Montserrat founded upon a thriving modern economy with a friendly, vibrant community in which all our people, through enterprise and initiative, can fulfill their hopes in a truly democratic and God-fearing society. I thank you.
Okay. I would want to stand on the existing protocol. The permanent secretary, the CMO, and all other protocols observed. I just want to use this opportunity to appreciate you all for the warm welcome. And, okay. I want to use this opportunity to appreciate you for the warm welcome and to bring you good tidings even from our office back there in Barbados. So online, I have our licensing officer who is in charge of the Barbados and OECS office to give a brief remark, Jane Gibbons, on the SRH in-country consultation policy and the joint SDG funds that is being implemented by UNFPA. So Jane, if you're online, you can go ahead. Okay, I think she's muted also. Okay, we can see you, but we can't hear you.
Testing. Can you hear us now?
Hi, are those in the room in Montserrat hearing me now?
Yeah, we can hear you now. Okay.
Okay, thank you. Thanks so much. I was saying good morning and good evening to those online and in the room. There's some online who might not be in the same time zone as us. Offering a warm welcome to all who have gathered for this consultation on the sexual and reproductive health policy for Montserrat. I wanted to turn briefly over to my colleague, Michelle Dunn, who is the coordinator for the joint program, to offer a few words, and then I'll come back in and just say some quick comments before we continue. So over to Michelle.
Good morning, everyone. Thanks, Jane. I stand on the existing protocol. As Jane said, I'm the Joint SDG Fund Coordinator for the Integrated Population Data and Policy Solutions to accelerate the SDG achievement in Barbados and Montserrat. Chairperson Dr. Watson, to all the government ministers present, to the Ministry of Health and Social Services, to our healthcare workers from the private sector, to representatives from the migrant communities, legal department, non-government organizations, community-based organizations, youth representatives, faith-based organizations, parents from the Parent Teachers Associations of nursery, primary, and secondary schools in Montserrat, to my UNFPA and UN Women colleagues, to our consultant Isola, to everyone, a pleasant good morning, good afternoon, depends on the time of the day on your end. This UN Joint Program on Integrated Population Data and Policy Solutions to accelerate the SDG achievement in Barbados and Montserrat is being implemented by the Joint SDG Fund to accelerate achievement of the SDG goals in Barbados and Montserrat by 2030. And it aims to facilitate increased access and availability of quality real-time population data for SDG monitoring, development of population policies, and to conduct gender analysis with focus on SDG 3, which is health, and SDG 5, gender. SDG 3, Target 3.7 aims to ensure universal access to sexual and reproductive healthcare services, including for family planning, information and education, and the integration of reproductive health into national strategies and programs, while SDG 5, Target 5.4, seeks to recognize and value unpaid care and domestic work through the provision of public services, infrastructure, and social protection policies, and the promotion of shared responsibility within the household and the family as nationally appropriate. This two-year joint program, 2022 to 2024, is being implemented by UNFPA and UN Women and supported by the UN Resident Coordinator's Office. And it actually aligns with the United Nations Multi-Country Sustainable Development Cooperation Framework 2022 to 2026, particularly Priority Area 2, Equality, Well-being, and Leave No One Behind. I will hand you over to Jane for some brief remarks as well. Thank you.
Thanks so much, Michelle. And just a little bit on UNFPA. I know most of the people in the room and online are aware of our mandate, but just to say that UNFPA is really dedicated to improving reproductive and maternal health worldwide. Our focus, of course, is on the Eastern Caribbean based on where our office is located. With respect to maternal health, we want to ensure that women have access to quality antenatal delivery and postnatal care. In terms of our family planning support, is to ensure the provision of contraceptives and family planning education to help individuals make informed choices about their reproductive lives. With respect to adolescent sexual and reproductive health and rights, we support the offering of education and services also tailored to the needs of young people and vulnerable groups. And with respect to gender equality, we work, of course, alongside our other UN agencies at UN Women, for example, to address gender-based violence and promoting the rights of and empowerment of women and girls. So with respect to the sexual and reproductive health policy, we are committed to working along with you based on your context in Montserrat to develop a policy to ensure reproductive health services, which of course are critical to the health and well-being of the entire community. And I should also mention that in addition to the development of the SRH policy for Montserrat, through another project called the Build Back Equal Project, which is being led by UN Women and also being implemented by UNFPA in St. Lucia, St. Vincent and Grenadines, Grenada, and Dominica, we are also providing support in developing SRH policies in those countries. And that work is also very advanced. So I just want to thank all of you, government, the local points and stakeholders, our women colleagues. We have Angela Davis online with us today, for investing in this work. And I want to wish you a successful consultation and commit our support in the next steps moving forward. So colleagues, I am moving between a couple of meetings this morning, so I won't be able to stay online, but I know you're in a very good hands of our colleague, Mr. Odo, who's Isola Garcia, and others. And I thank you for your time. Over.
To work cooperatively with Isola, our consultant, who coincidentally is online as well, and Dr. Watson, as well as Dr. Mosley, for gather your feedback, your input into this policy document, which is still at the draft stage. Because the inputs that you make will go a long way in helping to ensure that the policy has the local context of Montserrat. So once again, I appreciate you all for coming, and I wish you, all of us, a fruitful deliberation. Thank you.
Thank you very much, Mr. Odo. Thank you, Ms. Jane and Ms. Michelle. So we're now going to move on to a presentation by the consultant for the Sexual Reproductive Health Policy, Ms. Isola Garcia. Over to you, Ms. Garcia.
Hello, everyone. Good morning. My name is Isola Garcia. I am a national of Trinidad and Tobago. It is my absolute pleasure to serve in this capacity to my fellow brothers and sisters in Montserrat. Could you, Dr. Jones, let me know how much time I have? I suspect that we are a bit behind time, and I'd really like to give way for to keep the time allotted for the table discussions. So I will set the time on my end as well.
You have about 45 minutes, Ms. Isola.
Okay, thank you. And you will let me know when you are seeing my screen, okay?
Seeing it.
Okay. So let me just run the slides. Okay, so I'm at slide 1. So again, thank you for the privilege of being able to serve you this morning in this capacity. The slides are set up to walk with you with the document that you have on your table that you will be consulting on a little later on this morning. So we've got about 8 sections. And they're fully comprehensive. We give the background and so on. We delve into the sub-thematic areas, and we will look at some laws and so on, and then we will go into the summary. So the purpose of crafting this sexual and reproductive health, at the end of the day, we want to produce a policy that guides national multi-sectoral action to further secure the sexual and reproductive health and rights of the population in Montserrat. And this in turn, of course, supports Montserrat's national development goals of achieving a healthy and viable population. So far we've since January of this year, we've had a desk review, and it's still ongoing. We're gathering new data and updated data with every consultation we have. We've had virtual consultations. The Ministry of Health as well has had its own in-house consultation on the desk review. And today, here we are with your in-person consultation. So we're really hoping to achieve some outcomes with the development and with the implementation of this policy, not the least of which we want to improve maternal health, reduce maternal mortality and morbidity, and manage and prevent the complications of unsafe abortion. We want to improve the high quality SRH services and family planning that you already have and are delivering in Montserrat. We like to improve prevention and control of STIs and HIV, improve the treatment, the prevention and treatment of breast cancer and cancers of the reproductive tract for men and women, and of course have universal access to services, leaving no one behind. So is someone saying something? Okay. So as we go along, what we have considered throughout in all the desk review and the consultation so far, and we're asking you to consider today at your on the table discussions, we are looking at the context of SRH, or from the global, regional, and the national perspective. So we have considered from the global perspective guidance such as obtained in the 2030 Sustainable Development Goals. Regionally, we have the Strategy on Women, Children, Adolescents Health. Nationally, we have the Montserrat Sustainable Development Plan and the recently developed population analysis. We also want to consider issues of gender mainstreaming, recognizing and integrating the different circumstances and the needs of men and women into the design of this policy. And we are also taking a human rights-based approach, looking at principles of equity, non-discrimination, participation, indivisibility, and the rule of law, and in terms of that HRBA framework, ensuring that we have services that are available, accessible, and acceptable at the healthcare facilities, and goods and services as well as essential components of the right to health. And we also want to look at the roles and the duties of the rights holders. Those are the beneficiaries of this policy. Early on, I think it would have been the PS who was speaking, who spoke of participation. So that's one of the things we want to ensure, that the beneficiaries are part of the process, which is why we're all here today, and the duty bearers who are also in this room today, that we understand our rules and we bear them out. So we're delving right into the first section. And sorry, let me set my timer. I failed to set my timer. Thank you. And please flag for me if at all you're not hearing me. So one of the things that we are still pursuing is getting updated data. So some of the data we have here, updated data is still coming in, but we have seen, for example, that we have already limited data on adolescents. We have no data on men, boys, migrants, LGBTQ in terms of their SRH needs and their status. We know, for example, that on average, women have 1.6 children throughout their reproductive lives. Birth rates are low, declining, and below replacement level, as indicated in the following years that you will see on your screen. The average birth rate between the years 2015 and 2023 is around 41 births per year, and in fact, only 25 are projected for 2024. Oops. Right. Data suggests that there's early sexual debut before the age of consent, and there's one secondary school on the island, I gather, and therefore it would be good to plan around how we bring CSE, for example, to the schools. We have an adolescent birth rate per 1,000 women between the age of 15 to 19 years old, of 50.2 in 2022, and that translated to 4 births. We have an aging population as of 2023. 18.1% of the population were over 65 years old, 12.2% under 15 years old, and that means we have a dependency ratio of almost 44% per person. That means persons in the working age of 16 to 64 of supporting persons below the age of 0 to 15 and over 65. And some of the barriers that would have come up and which you will discuss today, for example, which prevents full access to family planning services and commodities, for example, would be the incongruence between the age of legal consent and the age of majority, respectively 16 and 18. And we need to discuss how that lines up with the Convention of the Rights of the Child, and even looking at child-enforced marriages and unions. We saw that there were no SRH services. You need to be accompanied if you are under 18 years old by your parents, an adult. We saw as well that there was no comprehensive sexuality education, HFLE, and that students have a poor knowledge of STIs, safer sex. There is a limited range of reproductive health commodities, contraceptives, and so on. And we saw as well, coming through the research, that SRH services and reproductive health commodity fees for nationals and non-nationals, they're different. And therefore, for the non-nationals, fees may be a bit prohibitive, especially those who are falling, migrants especially, who fall in the lowest wealth quintile. Stigma and discrimination in terms of persons LGBT, we don't have any data, but we have information coming in from healthcare workers in terms of stigma and discrimination as well, in terms of what prevents people from accessing services. We have an aging, we saw that there's an aging a policy addressing the care of older persons, but perusing through that, I did not see any information on SRH, the status of and the needs of older persons as well. And while there's no legislation, there is a practice in terms of husbands signing and to consent for their wives to have access to tubal ligation. So some of the facilitating factors in terms of family planning services and commodities we've seen are that SRH services are mostly free to nationals. They're mainly integrated. There are adequate facilities, human resources, equipment, and medicines. So now that we have an idea of the status, what you will be called to do on your desk and during your discussions is to provide some recommendations and look at the multi-sectoral actions. Who should do what, when, how? And in doing so, we want you to align these to some SMART objectives and looking at the 5 policy outcomes that we had before, and you may find more. We want to understand surveillance and what's done now, how are data gathered now, and what do you then do with that data? How is it monitored? How is it evaluated? How is it used for planning purposes? So you'd see the presentation follows the format of these 2 slides, which also is a requirement in terms of the discussion on the desk. So it may seem a little repetitive, but we are also just doing doing it in this format so you're accustomed to seeing what we would be discussing on the desk. So in terms of this area, some of the recommendations coming through so far, the need for an improved range of contraceptives, for improvement in patients and parents' education on SRH, including on contraceptives. This is for their own knowledge and for their own improved health and that of their children. alignment of the age of consent for SRH and to the age of consent for sex, abolish MOH policy and practice where husband sign for wife in terms of access to services for tubal ligation, for example, and the need to evaluate the health education program in schools to improve adolescent sexual and reproductive health. Even looking at, there was a couple suggestions of looking at and facilitating hygiene and menstruation education and facilities, including sanitary bins and so on in public spaces. Moving on to maternal and neonatal health, we saw that this is an area where Montserrat is doing quite well, where ANC visits and ANC in the first trimester stood at 100% respectively. We've got 100% of births attended by a skilled birth attendant, a midwife, doctor, or both. Maternal deaths, so far the data that has come in recent times, we've had 1 each in 2016 and 2020, 3 neonatal deaths in 2021, low birth weight 3 each in 2019 and 2020. I have a question mark on breastfeeding in terms of, because we know that is important to the health of mother and baby. So this is where some data are needed as well. So again, you'd be called on your desk to look at barriers and facilitators. And given that I don't have the full time and this information is on your desk, I will also skip through some of these. But just to say that Ministry of Health has noted that they've got the protocols, equipment, medicines, blood products to manage postpartum hemorrhage, which is one of the key issues surrounding maternal deaths, and that staff are also trained in this area. So again, same, whatever your recommendations, make sure that they align to a smart objective policy outcome, and that we look at how data is going to come in, what are the opportunities for data sharing and planning and monitoring and evaluating programs. Looking at infertility, subfertility, and SRH disorders, we have seen that average childbearing age is 29.2 years, and women on average have 1.6 children. I know that one of the, from reading the population service situation analysis, Montserrat is seeking to increase its population. From the scenarios that were conducted in that study, it says that it does not augur too well in terms of a substantial increase based on fertility at this time. And there also needs to be, in terms of fertility services, some services are available locally at a cost and some others are abroad. And these are both barriers and facilitators in terms of investigation into the issue of fertility. And we need some more data in this area. Again, discussing who should do what are your recommendations, making sure that they are aligned. On the issue of prevention of abortion and management and of complications from unsafe abortions, data that we have so far, 3 abortions recorded in 2019, 6 in 2020. We did not have any data on induced abortion, and we did not see any guidelines on post-abortion care. So some of the barriers that came up during previous consultations, we know that abortion is a criminal offense, except for medical reasons. Cytotec is sold over the counter in the private sector and could be unsafe when used unsupervised and misused and can lead to complications. However, post-miscarriage and abortion care are available in the public health sector, and there are protocols to manage this. Again, same format. Who should do what? What are some of the recommendations? So some of them coming through so far is to revise and possibly amend the laws and to review the policies and definitions on neonatal death, maternal death, and abortions, and so on. Again, making sure that your discussions look at the evidence, look at the recommendations, making sure that the recommendations are aligned to that outcome that improves sexual and reproductive health and rights in Montserrat. On the prevention, early diagnosis and treatment of breast cancer and cancers of the reproductive tract, we did not have too many recent data coming in so far. I recall data from the Health in America's report done by PAHO that between 2006 and 2010, there were 5 deaths due to prostate cancer and 5 due to breast cancer. But however, we know that the situation in America is much broader than this. For example, breast cancer, there are more than 491,000 cases yearly and more than 106,000 deaths. Cervical cancer, despite being highly preventable, we have 35,700 women die of the 72,000 who are diagnosed. And cervical cancer is actually 3 times higher in Latin America and the Caribbean than in North America. We've seen that HPV screening is done locally, but the samples are sent abroad. HPV vaccine was introduced in 2018, but the uptake was low. And we understand that there is a pending HPV awareness program that would herald the reintroduction of vaccination for HPV in Montserrat in 2024. Some of the barriers, of course, HPV vaccine, so we need to look into that and address that. Education for men and women is needed on this. And for poor women, for example, we saw that pap smear, even at EC 100 EC dollars, is prohibitive for even poor women. So facilitators, pap smears are available locally. Protocols are being revised for cervical cancer screening and the management of pre-malignant diseases. And of course, we have some, we were able to do some scans to enable early diagnosis and care. One of the facilitators in terms of the cost of HPV vaccines, it's including in the PAHO's revolving fund where countries can benefit from bulk purchases at a unique price. And that can help in terms of your vaccine introduction and strategies to strengthen cervical cancer screening. Again, same format. Look at your recommendations, ensure that they align to the outcomes that you want to see in sexual and reproductive health and the rights of the population. Prevention and management of STIs, HIV, and AIDS. Again, we also need to have some updated data here. For 2017, we saw that data coming through. I believe this is from PAHO again. It's estimated new HIV diagnosis per 100,000 population estimated at 37.8%. And in 2019, and this is coming from the recent population situation analysis done this year, that in 2019, there were 11 reported persons living with HIV, 2 of whom were recorded in 2018. No deaths due to AIDS recorded and no records of the persons on island living with HIV. Elimination of mother-to-child transmission of HIV and syphilis and ANC testing for HIV and syphilis are at 100% respectively. Between 2010 and 2021, no pregnant women with HIV or syphilis. There were no recipients of treatment for HIV, no vertical transmission, no congenital syphilis per 1,000 live births. No congenital infections during the 2021-22 period for HIV, syphilis, Hep B, Hep C. We are still lacking data, and that, and we really can't say what's happening with the progress of the 95 by 3 targets. And we don't have this disaggregated data as well, and that's always problematic. We always say missing data is missing opportunities for prevention and missing care and treatment as well. So we do need some disaggregated data in terms of unique tests of residents and visitors and so on. And some of the facilitators noted, for example, all blood donors and expectant mothers in Montserrat are screened for HIV. They're offered since 2005. All pregnant women have been offered testing for HIV, Hep B, and syphilis. Again, same format. What are some of the recommendations here? In terms of surveillance, for example, how do we overcome some of this? We know that there is the health information system is now being expanded on the ground. It's now in 3 of 4 sites, 3 of the 4 health centers on the ground. And it therefore we have an opportunity to expand our surveillance. Section 4, the provision of age-appropriate comprehensive sexuality education. Again, some data are dated here, but it was still interesting nevertheless to present a CAP study done by UNICEF in 2006-2007 showed that many adolescents were engaged in sexual activity before the legal age of consent, with 76% of males and 66% of females already sexually active. And I believe the denominator was 230 children. A gender assessment showed that the sexually active participants, 13% of the respondents had either been pregnant or got someone pregnant at the time of the survey. We know that pregnant girls are not prohibited from attending school, but they face stigma and discrimination. In one case, we heard it may even come from the attitudes of some teachers, and they face embarrassment in terms of returning to school. And we know that that could be a problem, especially when we are seeking to enhance the education of girls to really put a stop to that cycle of poverty for themselves and for their children. So some of the barriers that have come through from consultation so far are that adolescents rely on information often inaccurate from their peers about sexuality, pregnancy, and contraception, as schools may not offer the comprehensive sexuality education. Religion was one of the factors that hindered a more incisive debate about sexual behavior at school, and this came through that 2014 gender assessment, and that there were no policies that we found so far guaranteeing the right to CSE, and no data was found on its status or progress of the introduction of CSE. Montserrat, as a facilitator, guarantees education as a right by law, and from the Ministry of Health, guidelines in terms of sexual and reproductive health looking at adolescents are being looked at the moment, updated. Same format, look at the recommendations, make sure that we look at the evidence, look at the recommendations, make sure that they align to the policy outcomes, and discuss how we collect the data, what we do with that data, how we plan to share and monitor and evaluate programs. One of the things, because Montserrat is a UCOT, that they can look at, given the incongruence, for example, between the age of consent and the age of majority. Some Caribbean countries, they have actually done the reverse, rather than in terms of the alignment, aligning the age of majority downward to the age of consent. They have increased the age of consent to 18, still ignoring the fact that that there is early sexual debut and that there is a lack of comprehensive sexuality information, and therefore adolescents continue to be at risk. One of the things that as a UCOT, you can review, for example, the Gillick competency model and the Fraser guidelines, which helps people who work with healthcare providers, counselors, and so on. It helps help them when they work with children to balance the needs by listening to young persons so that they understand what their needs are and how they need to keep them safe. You know, they are encouraged to speak with their parents, to let their parents know what is happening. But this is something that the links are there, and you can check this at your table as well in terms of having discussion on that. The Gillick Competency and the Fraser Guidelines refer to a legal case in the 1980s, which looked at whether doctors should be able to give contraceptive advice to young people under 16 without parental consent. So this is something that you can discuss. What is a healthcare provider to do? Turn away a young person if they clearly are at risk? Help them to encourage their parents, or so these are some of the things that this would help to sort through. Prevention and management of gender-based violence. Let me look at my time, 23 more minutes. For the period 2005 to 2021, coming from the PSA population situation analysis of this year, 176 reported domestic violence cases, 56 rapes or sexual offenses, and 1 interpersonal violence death. So some of the things that came up as that we need to do, we need to look at the situations of violence, of course, what keeps people, survivors in relationships. Poverty is linked to this, the acceptance of interage relationships, vulnerability of young people. So some of the cultural practices, are there cultural practices in Montserrat that perhaps impact on violence? Looking at some of the facilitators, Montserrat is signatory to some key pieces of conventions that address SRH and GBV. And we'd like you to look at that and look at the ones that you're not party to in terms of what needs to be done there. All right. Won't go through that slide. It's the same format. In terms of health systems, we will look at the essential package of services and, of course, the minimum initial service package. So here are some of the services that Montserrat currently provides. So we need to look at, is this the full package of services that are needed? And what else is needed? What is provided on island, what is provided off island, how can we be more in sync with meeting the needs, not only of nationals who pay a fee, but even where the fees are prohibitive. For example, we have CARICOM nationals who will pay 1.5 times the rate that nationals pay for services, and non-CARICOM migrants and persons who would pay 2 times the rate for the services. What risks would these issues pose? For example, if persons do not access services, do not access testing for STI or HIV, for example. So we look at those risks. So what are some of the barriers? Cost came up as some of the barriers. Stigma and discrimination. We saw that some of the data coming through shows the vulnerability of migrants, especially Spanish and French-speaking migrants who may not be able to pay for the services, language barriers. So we need to also look at that. Some of the facilitators, of course, for Montserrat, services are free to Montserratians. Some, and we see here under the facilitators, it's largely subsidized by governments, and certain categories of persons are exempt: pregnant women, the elderly, children, adolescents, and so on. So looking at fees, looking at what needs to happen so that we achieve universal health coverage and universal health care in terms of fees not being burdensome and keeping people away from services and then them not being able to access services. Some of the recommendations coming through is looking at the need for addressing service delivery, looking at integrated record system, looking at supplies, logistics, information system support, medical support needed, training needs of staff and supervisors, updating relevant guidelines, looking at the infrastructure and referral systems, looking at management and oversight of services, in addition to looking at the fee and cost structure. The minimum initial service package, of course, in a crisis, the supply and delivery of a comprehensive package of SRH is interrupted, and we need to ensure that the provision of SRH information and services which are threatened, that we still are able to maintain these. Failing to do so will put persons at risk and deny them their rights to these services, to life-saving interventions. So by minimum, we mean basic, limited, essential reproductive health services, initial, in terms of its use in an emergency without a site-specific in-depth reproductive health needs assessment, services of reproductive health care for the population, and package, it's coordinated, planned, and in terms of supplies and activities. So we don't have information on what is currently supplied in Montserrat, but we have UNFP on the ground who can assist with this. Some of the recommendations and the multi-sectoral action noted so far is that we need collaboration among the partners of supporting infrastructure and knowledge base in terms of the capacities of stakeholders as well, and the resource networks to lessen the risk of a stable and comprehensive SRH system being interrupted. Access to essential medicines. So we've heard that the health facilities do have the essential medicines needed. And there we have a report from 2023 from UNFPA that looked at the landscape of reproductive health in the Caribbean, situational monitoring, and we saw some of the medicines here that are noted in terms of protocols, equipment, blood products, management of postpartum hemorrhage, trained staff, those things are there. However, limited range of reproductive health commodities, of course, which were disrupted during COVID. And that goes back again to our discussion, for example, on the MISP. Again, some of the recurring themes in terms of barriers, the fees that may be prohibitive for non-months rations. The cost depends on the type of method chosen. However, we do have a good base in terms of the healthcare for nationals. And we saw that government provides 100% funding, for example, for contraception. Again, same modus operandi, look at what is happening, look at the data, the evidence, look at your recommendations, who should do what, and looking at aligning them to the policy outcome. We know that Montserrat does not yet have its own formulary, and that it uses the OECS medical product list, but that work is currently ongoing in terms of developing its own list. In terms of leadership and government, we know that Montserrat is focused on creating a healthy Montserrat. I noted the vision, I believe it was the PS. I came in we were connected very late into the audio, but I think it was the PS who spoke to the vision of Montserrat for a healthy and wholesome Montserrat. So we know that leadership and vision is there. And it's one of the reasons we're addressing the barriers today of not having an SRH policy or a plan of action. And some of the facilitators, we know Montserrat views health as a fundamental human right. And the Ministry of Health and Social Services is really aiming to ensure that eventually all persons, regardless of their socioeconomic situation, will have access to an essential package of quality health services. And we saw that significant support is being received from the Foreign and Commonwealth Development Office in the UK in terms of Montserrat's health transformation program. So again, same modus operandi, look at the evidence, look at your recommendations, who needs to do what, align them to policy objectives, outcomes, looking at surveillance, data sharing, and so on. Your health information system, we understand that 3 of the 4 health centers now use a health electronic information system. And of course, this will be expanded to all 4 health centers for the use of clinical management and surveillance, and personnel continue to be trained. We need to look at the type of reports, the data going in, the type of reports that we're producing, how we're acting on that report, how we're using this system for surveillance, monitoring, and evaluation to have an evidence-based or evidence-informed planning and programming for SRH. So we're hoping, of course, that having the system on board will help with the ease of data disaggregation. Again, missing data. If we don't know the situation of subpopulations, we cannot plan for them, for their prevention, and for treatment and care. And we saw incomplete and the need for updated data as well. Okay, 11 more minutes. But I think we get the gist of how we're working in terms of the health workforce. We know that there's limited human resource capacity. So for discussion, what we want to know, for example, what is the status of health workforce planning for Montserrat and filling the gaps. And we know that some of those gaps are being filled. Dr. Mosley, who's your obstetrician gynecologist, is on island now supporting a service that was previously referred outside of Montserrat. In terms of finance, we need to also discuss what is happening here. We know that services are largely subsidized for non-nationals. Looking at the adequacy of financing in the health sector and for SRH programs, do we have the budgets that we need to deliver the services that we need? Some of the barriers, of course, to this, we know that there is limitations on the internal revenue generations, dependence on the UK, and service fees can be prohibitive as well. We saw that there's a social security fund that aims to supplement income lost during sickness, maternity, employment, injury, and old age. And those are some of the positives that are on the ground. Again, same modus operandi. When we're looking at international conventions, we saw that Montserrat has ratified some important ones linked to SRH and gender-based violence. On your tables, you have this information. Look at the status of the non-ratified ones, the pseudo-optional protocol, for example, looking at persons with disability, looking at trafficking, looking at the regional conventions on the prevention, punishment, and eradication of violence against women that protects vulnerable people, including lesbian, the LGBT community, and migrants. Same modus operandi. Look at the data, look at your recommendations, and alignment to the outcome of your policy. Local laws, we saw that in terms of, we don't have laws that criminalize trans persons, but we do have, and there are no laws, for example, in terms of regarding same-sex civil union, same-sex marriage, the adoption by same-sex couples. we went through that pregnant girls are not debarred from re-entering school. One of the things that came out that perhaps you can discuss as well is really looking at that the incongruence between the age of sexual consent, the age of marriage, looking at the definition of child-early forced marriages and unions, but also looking at that bit of the legislation that looks at where a person under 18 may marry but must get consent from the parent or guardian. And we saw as well that marriage is void under 16, but that the governor, in his discretion, if for serious reasons consider it to be in the best interest of the intending spouse to do so. Here we need to consider what's in the best interest of the child as well, as per the CRC, the Convention on the Rights of the Child. So some of those things should bode for good discussion on your table. I will move on. 8 more minutes. So some of the things, not a full summary. So we need to focus on data strengthening and the delivery of an integrated package of SRH services, looking for where services are at the moment and where SRH can be integrated. We need to place emphasis on educating the public. How can NGOs, CSOs, FBOs, media be engaged in this? Focusing on quality care that is based on evidence, decision-making that is based on evidence. We need data strengthening, and even there may be a case for doing some investment cases as well. For every dollar you spend, what is the return? Looking at further capacity building of healthcare providers. Number 5, looking at the provision of adolescent SRH information and services. We know that adolescents, they have access to phones, social media. Let's ensure that they get the correct information that they need. Looking at services for vulnerable populations, identifying them and moving toward services for them that aren't prohibitive, and that we really do achieve our goal of universal access to healthcare. And we need to identify and provide these services. We need to look at the legislative and policy reforms, making sure that legislation and policies across the multi-sectors, that they are aligned, and facilitating the development of protocols and guidelines to facilitate SRH. So in summary, some of the glaring things that came out is that we really do need data. We need disaggregated data. Again, missing data means missing opportunities for prevention, missing care. We need to act on evidence. Perhaps you can identify some investment cases that may be needed. What is the result if we don't act on the evidence? And what would be the result, the outcome, if we do, in terms of really achieving Montserrat's overall vision? An old African saying, I'm told, is that, given this big task that lies ahead for us, that has multi-layers, we have culture, we have emotions, we have evidence, we have different perspectives of everyone in this room. It's a big task, like a big elephant. So you can eat an elephant one bite at a time. I understand that was a friend of mine from Nigeria. He would always say this to me: you eat an elephant one bite at a time. In the Caribbean, we sometimes say drop fills a bucket. In social and behavior change, we say think big, start small, but start now. And that's the start we're making today. And so just in my remaining few minutes, I have about 4 minutes and 30 seconds. I shall just give some guidance for the breakout session. Before you go to break, I believe there are some nameplates on the tables that identify the topic areas. We've given 3 areas. You only have an hour and a half. So we would like to give you at least half an hour each for 3 of the topics that you are assigned per table. You can identify your table and perhaps go to it prior to your break or as you're making your way to your break. Each table has a Ministry of Health and Social Services colleague who will be your note taker. The group, you should elect a moderator, make sure that everyone is contributing. Everyone's contribution is important, and elect a presenter. The presentations will be compiled on our Ministry of Health colleagues' laptop. Make sure to register the table as well so we can understand the contributions as well as the contributors. And if you're finished with your contribution to your table and you see another table where you want to make a contribution to that particular topic, feel free to do so. So I think with that, this is my last slide, and I'd like to wish everyone a very productive session and a productive day. And I really do thank you. And I look forward to continuing to serve on this very, very important policy to Montserrat. Thank you.
Thank you very much, Ms. Isola. So at this moment, I just want to remind you all, please kindly scan the barcode that is on your table. If you have any issues, if you do not have a barcode reader, you can simply go into your camera to scan it. If you're still having issues, let me know, but I will also bring around a form for you to also register, okay? So at this moment, we're going to take our break. It's going to be 25 minutes, and when we return, we'll discuss the round table discussion. Thank you.